I'm Irene. My last name is Piryatinsky, but I go by Irene. It's just a lot easier. Um, I am a licensed psychologist. I'm a board certified neuropsychologist. Older adults, geriatrics is my passion. It's what I do best. I've gotten into the world of hydrocephalus a while ago during my training, which was quite some time ago. And it's been a passion of mine. I've been an active presenter at the Hydrocephalus Association. And so I'm really here to serve you. Um, I'm happy to answer any questions if you want to know about my credentials. But really, I want to focus on hydrocephalus um, as much as possible. One of the things that so I tend to speak fast and because I'm passionate about what I do, and I have an accent. So if I need to slow down, just say so, unmute yourself, say slow down, and I'll try my best to slow down. And hopefully we can all understand each other. I told you I'm board certified. I'm an assistant professor of neurology at Tufts. I'm not selling you anything. I have nothing to sell except hopefully some of my ideas. So there's no conflict of interest of any kind. And we have here in Massachusetts a beautiful training program that I run, teaching future neuropsychologists how to be the best at what they do. In terms of what I'm hoping to do today is I'm hoping to just give you a little bit of information about hydrocephalus, really very little. You guys know more about hydrocephalus than I do. Then I want us to talk about early interventions. We'll talk about baseline evaluations. We'll talk about some recovery consideration. We'll talk about monitoring post-surgery. I'll really hone in on cognitive rehab because that's what I know most about. And then what I also like to talk about is kind of the research aspect of my work is this idea of perception of outcomes or perception of how you're feeling post-surgery. And then maybe touch a little bit about what you can do and what your families can do for you. I know there's a lot of you, so I don't know if this is going to work. I'm going to propose if it's total fail. I love discussions. I love when people get to ask questions and I get to share my 2 cents. So if possible, we may want to try this. If you have a question, unmute yourself. I don't care about the order of my slides. I care about satisfying you. I care about you hearing information that you want to hear, with limitation that there's a lot of you here and with the fact that we can't please everyone. So with that, and I want to leave a little bit of room for questions. So if you have questions, start, I think, typing them up, or if new questions come up, do that as well. So I was told to keep things entertained, and you'll probably see my archaic skills in putting the slides together. So I was trying to be cute and it didn't work. So here we go. Hydrocephalus is a disorder that Hakim and Adams put paper about, and we're here talking about communicating normal pressure hydrocephalus, usually develops later in life. And the way that I'm thinking about hydrocephalus always is it's one of the only few reversible neurological conditions that we know of. So thank goodness we know how to identify it. We're much better at identifying it earlier, faster. The faster we identify it, the more neurologists, neuropsychologists are aware of what NPH is, the more likely we can start thinking about interventions early. So when we're thinking about our patients with hydrocephalus, almost every adult that walks through our clinic gets asked about what? Incontinence, gait, and cognition, right? So these are the first things we usually cover. And as you know, and as I'm learning, as I'm getting older, right, our bodies slow down. We may have some incontinence for other reasons, right? Prostate issues, pelvic floor issues, right? So there's a lot of comorbidities that could be going in. So it's your job, really, and we'll talk a little bit more about it, preparing for your appointments with doctors and making sure that you adequately describe as best as you can the symptoms that you're experiencing so that we can be helpful in terms of sorting those symptoms out and thinking where you might be in terms of the symptoms and what we should be thinking, ruling in and ruling out about, ruling in and ruling out. A lot of us, as we get older, have gait issues. So we always want to hear about your gait. We want to hear, is it difficult for you to go up the stairs, down the stairs, right? We're always asking you these questions about your floor to foot clearance. So as we know it, when you're coming to the doctor's office, you most likely have heard those questions and most likely have identified with at least some symptoms of hydrocephalus, which is wet incontinence, feeling unsteady, and having cognitive concerns. We categorize hydrocephalus in two categories. We have secondary NPH, which is known causes usually head trauma or brain infections. And then we have idiopathic hydrocephalus, which usually the cause is really unknown. So in my case, when I see kiddos or children, I tend to think of the secondary hydrocephalus post head injury. And then when I see my older adults, I tend to see idiopathic presentation. So one of the things that is very important, and you might be already far from this stage, is, but I think it's always good, particularly if you're part of support groups, if you're helping others in terms of early identification, is knowing the symptoms. Some of us have gotten very good at listening to our patients about the symptoms and knowing how to filter information, but it's still a heavily underdiagnosed disorder, which is why often we say to you, our patients, go to someone who knows hydrocephalus, meet with someone who's a professional, meet with someone who's treated patients, right? And you're a surgeon, should be well-versed in surgerizing patients with hydrocephalus, and neurologist should be well-versed in movement disorder. So we encourage you very much usually to seek second opinions, to talk to other doctors, and to talk to other patients about their experience. Diagnosis relies very heavily on clinical examination and your report. So I can't tell you enough how important it is for you to list your symptoms clearly to us, not only at the beginning, right, but also as you go through the process of post-shunting experiences. We really need to know about any comorbidities that might be going on. So have you had hip issues? Have you had vascular issues? Have you had those head injuries? Is there a history of intellectual disability? Is there any learning attentional issues that we need to be aware of as we're kind of taking you through this process of baseline assessment, surgery, and then further monitoring of your symptoms? And in some cases, actually going back and doing more than one surgery. I don't know if any of you have had that experience. We do know that early diagnosis intervention are crucial for improving long-term outcomes. We know that we are able to prevent cognitive decline and gait decline if we get to catch you earlier. So I'm just also promoting this idea that the sooner we identify the symptoms, and then the sooner post-surgery you keep your doctors informed on what's going on with you and don't keep it to yourself, the more likely we'll be able to identify how to better help you. One of the ways some of you may have had the experience of getting this process going is through what we call baseline evaluations. So we are that man in the center, that's a patient, right? And so we're thinking of various domains. We work as a team. Most neurologists never work alone. They have someone like me, a neuropsychologist, on their team, right? So we do cognitive baseline assessment. Go ahead and raise your hand if you had neuropsych testing, if you don't mind. If you don't want to share, don't. But if you feel like sharing, ooh, look at that. Okay, beautiful. I see hands. Okay, you don't have to share. Okay, so cool. The neuropsych assessment. Nobody walks into my office, says, please do a neuropsych testing on me, right? The most unpleasant probably experience, right? You go in and someone gets to ask you questions about orientation and ask you questions about memory, and you usually come out grouchy and not so thrilled with experience. So, but that needs to be done in order for us to know, wait, what do we need to be looking at? Are we thinking there's attentional issues? Are we thinking there are memory issues? Is the profile very classic-y of NPH? Is there something else going on, particularly if there's a family history of early Alzheimer's, of any other what we call neurodegenerative process? We also often really encourage you to meet with a behavioral health specialist. So mental health provider who will talk to you about your support systems. As you know, going through the surgery, it's a brain surgery, right? It's very stressful. So having a family member, having friends, having a support network really helps. So if you're alone, if you're lonely, if you have a history of depression, if you have a history of substance misuse, we want to cushion you with that behavioral support even before the surgery. We also often have you meet with a PT, with a physical therapist, with occupational therapist. Again, the goal is to really make sure we know where you're at, because it's my job to make sure that we meet you where you're at before the surgery and after the surgery. How are we doing? I want to just slow down for a minute. Any questions based on what you're hearing? None of it should be shocking, surprising, but hopefully entertaining, useful. Okay, cool. Older age is one of the risk factors when we're thinking about what is waiting for us after the surgery, right? So we're thinking about recovery very carefully, even before the surgery. We are informing you of things that you should be thinking about and doing prior to the surgery. So if you've had sleep difficulties prior to the surgery, we'll probably work with you on sleep hygiene. We'll probably encourage you to discontinue watching television at night in your bedroom while you're laying down. So there's some things that we can modify. Age, we can't. So we're always thinking about what are some of the risk factors we need to be considering as we are thinking about the surgery, additional surgeries if they need to be done. We also know that one of the important recovery considerations is any medical additional problems that you may be having. The older we get, the more likely we have hypertension, we have hyperlipidemia, we have diabetes, we have falls. So we're thinking about these medical additional issues that we want to be aware, monitor, and treat as much as possible prior to thinking about the surgery. And obviously, that will help us think about you post-surgery. We know that longer periods before shunt placement, so if you've had hydrocephalus for quite some time, and if it took a while for diagnosis to happen, you've had physical changes, you may have a longer rehabilitation period. I think it's a fascinating concept to think about, because when we talk about recovery and when we talk about the baseline, one of the really important points I like to bring up is this idea of what is a baseline. Oftentimes, by the time you come to us, you've been living with the symptoms for some time. So this idea that there is a possibility, a hypothesis, that you've learned already how to adjust at least to some of the symptoms that you've been experiencing. If you have had gait difficulties, you may have started using a cane. You may have been walking less. If you've started having some cognitive difficulties, you may have been compensating already for some time. So by the time I get you, by the time your neurologist gets you, one of the very important questions I like to think about is what I'm seeing your optimal baseline? Or is it you already have adjusted to some of the difficulties that you've been having? The more intelligent you are, the more brilliant your brain is, the more likely you've kind of been quickly accommodating, quickly changing. So I take my time to think about where have you been and when did the symptoms start, which is why sometimes you find us super annoying. That's the feedback I get sometimes when we drill you with questions. But when did that symptom start? When was the first time there was leakage? When was the first time you started feeling like your feet are stuck to the floor and it's more difficult to go up the stairs? This is why often we think about or ask you to bring family members, loved ones, to hear that additional information. It helps me gather and put information together of what do we need to be thinking in terms of recovery considerations. You with me thus far? Yes? We're good? Amazing. Okay.
Irene, we did have one question in the chat. Could you define optimal baseline?
Oh, that's that's a $1 million question. Yeah. Optimal baseline is information. Oh, sorry. Information I gather from you, my patient, your doctor gathers, information I gather from someone you trust, and my baseline testing that I do. There's a concept you may have heard of, right? When we experience a decline, when we already in that decline, we sometimes say, but I was amazing a year ago. I remembered all phone numbers, all of them. I remembered birthdays of my coworkers and everyone else I met. That's your perception. So the optimal baseline is a combination of these factors. It's us listening to all that information and putting that together with the data. Because if you're telling me that your memory is incredible, but my scores are showing otherwise, or you're telling me I'm not depressed, but then a trusted person says, he hasn't been getting out of the house. This is not the same man you used to know. He's no longer volunteering. We put that all together to figure out, but where are you at that point? And then obviously the optimal baseline or the optimal functioning shifts based on where you are and how and that allows us to measure you over time. Does that answer your question? Trish, you had a question? I don't see questions. I apologize because I don't know what, but I think you need to unmute yourself.
I think that
There's a question about whether NPH is a form of Parkinsonism.
So Parkinsonism is one of the features of hydrocephalus. Sometimes patients experience tremor, and that tremor and that gait difficulty may be considered Parkinsonian.
Here, take a look at a new study that suggested naloxone.
How are we doing? We're good with questions?
Yeah,
I appreciate you checking on them, not ignoring them, just don't see them. Okay. So what am I here to sell? I'm here to sell the idea that the stronger your team is, the better. You have to have a team. The team approach helps us all get on the same page and make a decision on your functional status. It helps us all know where you have been based on these data points, and then what do we need to be thinking about post-surgery. We then help you decide what are your rehabilitation needs. Right? Because if you come with a walker, but you started using the walker for the past 3-6 months, we need to know that, we need to understand that, so that the optimal functioning is not to just not fall and trip, but also can we get you from a walker to a cane? Okay. So the comprehensive approach is very helpful. We're focusing on optimizing recovery and functioning, and that's different for everyone. For someone, functioning may be being able to pick up grandkids, hold them, hug them, spend a few hours with them. For others, it might be driving. For others, it might be managing finances. For others, it may be caring for their spouse, for their loved one. So everyone's functioning is obviously different. Our job is to figure out where do you see yourself, how reasonable, appropriate that assessment is, and then try to get you there as much as we can. And one way to do it is, drum roll, through effective communication, right? So if you are talking to your team, if you spend that time month before the appointment, taking notes, writing information down, you're bringing us all that juicy information that we want to have in order to know how we can best help you. Okay. This is what I got cute with my slides. Where there's always need to monitor and to adjust. The timely adjustment is very often based on your needs. You may have heard your doctors talk about adjusting your shunt settings so that there's no secondary changes, there's no secondary deterioration. Things are not getting worse because it's not adjusted. So early identification of symptoms indicating complications, such as headaches, such as confusion, all that needs to be brought back to your doctor so that they can monitor your shunt settings. The sooner we identify, the sooner we know where the problem is. We often push for additional assessments. We often push for additional PT evaluation, so physical evaluation, occupational evaluation if those are needed. We often ask for repeat neuropsych assessments done so that we know where you're at. You are coming in and we're relying on your self-report, but that is additional data where we have numbers to put to your experiences. Sometimes the root of secondary complications is some other problem. So if we hear your symptoms, we are much better at being able to then say, what else could be going on? And obviously it's much easier to do if you're an open book and we knew what was happening even before the surgery. Sometimes, based on what the symptoms are, you may have undergone through either shunt adjustments, or some of you may even had their shunt replaced. It's all about your needs. Any questions thus far?
Irene, we have another question in the chat. Linda had asked, what do you consider to be recovery?
We measure it in sequences. The recovery is like an umbrella term here. The recovery is your gait. You could not walk 10 meters in less than, few minutes. And now we record your gait, by the way. And now you're nicely, smoothly walking. You couldn't walk without a walker. Now you're walking without it. That's a recovery. You used to wear the pens all the time. Now you just wear them at night. Or now, instead of the pens, you're wearing a pad. Instead of now in incontinence, there's now leakage. You can never say the name of that game, so maybe I should stop using it. You love playing chess with your grandchild. I'm going to use chess. And before the surgery, you couldn't. And now you can. The grandchild might still be winning, but you have your opening back. That's recovery. Because if you think about it, well, the way I like to think about it is, my data is, I love my data. I love my cognitive data. I love looking at my standard scores and comparing them. But in reality, what you care about are these things. The reason we ask you to complete a urinary continence diary, a bladder diary, is because I want to know that the frequency of incontinence has reduced. It's no longer bowel and urine. It may be urine sometimes, right? So to me, the data matters. What matters to you is quality of life, which we also, by the way, assess by talking to the trusted people that you bring with you. And so that also becomes a point of recovery. Does that help, Linda? Yeah, okay, cool. Any other questions? Here's what we know from the data that we have. And hydrocephalus patients are hard to study. Kids with hydrocephalus are a little bit easier to study. this is harder to study, but we're doing a good job, and Hydrocephalus Association has been like incredible at helping us do that. So I'm not selling anything, just bringing up the idea, like having data be pulled is kind of awesome. Majority of patients, more than 80%, notice improvement after the surgery in their gait. So I love talking about honeymoon effect. We won't today, but this idea of post-surgery, I don't have the videos actually, but a few years ago, maybe some other day I'll show you guys a video, or your own living examples of what the gait looks like. But the gait improves rapidly. Some of you might have had a spinal tap done before the surgery, and then you had a silly person like me walk around and time your gait after the spinal tap, and it's a miracle. Like all of a sudden you're walking much faster, no shuffling. So we see that gait is a huge improvement usually post surgery. One of the things your doctor may talk to you about is if we're doing a spinal tap, or you have enlarged ventricles, but the gait is not your problem. There's sometimes a discussion about, is a surgery still recommended? In most cases it will be, but we're sort of like thinking how Linda is asking, what's going to be the improvement? What are we looking for with this brain surgery, right? Yeah, it's a brain surgery. So it's a serious surgery, obviously. So we're always thinking in terms of what symptoms we're improving. And so what we know is 80% of patients experience this very significant improvement in their gait. And then within weeks and months, you call and tell us that, or when we call you, you tell us that the gait continues to improve. Something has to be said, the more proactive you are, the more likely you already have your PT arranged, right? So you're doing additional things for yourself, right? So you're doing additional work to help your gait improve. So this is why physical therapy becomes important. We don't want to experiment with you. So don't, we don't want to say like, oh, you know what, don't start physical therapy. We want to see how you're going to improve spontaneously. We're kind of saying, let's get that physical therapy in, right? Let's train that bladder. Let's keep that bladder journal going. So the goal of what I want really out of this slide is for you to hear that the faster we start physical therapy, the faster we're going to start having you be physically active to your capacity, the more likely you'll see gait changes. We also, any questions?
Irene.
I just figured it out. I figured out the questions.
Hey, Irene, it's Trish. We have a question in the chat asking if you could provide a summary of best practices, maybe after the call. Your point about having a urinary control, diarrhea is a new idea. So other things like that.
Yeah. Is it okay to bring it up since we're on the incontinence slide?
Yeah.
Yeah. Okay, cool. So the way, and I'm a neuropsychologist. I love neuropsychology, but I'm a psychologist first. So, I never wore that hat very well of being a therapist, but I was trained in cognitive behavioral therapy. So this idea of structure, of this idea of thinking about what you want to achieve, how you want to achieve it, is very important to me in my work. So when I think about a bladder diary, it's not anything new that you probably didn't hear about, right? You probably understand what comes out of it. To me, it's just like if I would be a therapist, I'd have my patient track their mood. We're going to get to the mood question. I see it. But the idea is I would give you a piece of paper, which you can absolutely come up on your own, and you break down it by day, by hour, and you list when you had to go to the bathroom, when you went without an accident, when you almost had an accident, and when you didn't make it. It helps me when I see you to have a discussion about what happened. Are you holding it because you're watching your favorite show? Did you have a lot of water to drink before bedtime? So it helps me understand where the problem is. And then I use that data to structure bathroom routines. You go to the bathroom, you wake up, you go to the bathroom, you're about to go volunteer at the library. You don't go until you've gone to the bathroom, right? When you go, you have to go fully. You don't need to be rushing. You don't need to be on your phone. You go fully, right? So it just gives me data. So best practices are, we're all, you probably, as many neuropsychologists, there are opinions about what the best practice is. The overall message I want to leave you with, the best practice is comprehensive approach. The best practice is having a team. Not everyone is going to love the diaries, but if you're the type of person who needs data, then you're probably the type of person who's going to be taking notes before appointment, writing everything down, right? And going to your doctor with notes. You're probably going to have all your medication list ready for you. And so you're going to probably do the same with a bladder diary. Question, how do you know, Brenda is asking, how do you know if apathy is due to depression or other part of dementia related to NPH? Great question. We will get to it. We'll get to it. We'll get to it. Stay put. I can see the question so Diane is saying, I'm on my second shunt and the flow keeps needing adjustment and my symptoms not improving. I'm still trying to work full time, but even with the walker, mobility is getting worse. There's something other than a shunt that is being used to treat this awful stuff. I'm a PT again. I've gotten through a lot. And I'm really miserable and I just want to go out and walk my dog. A wonderful dog. I hear you so clearly. You're doing a lot, right? You are working full time. And I guess all of us can use the space to kind of take a step back. So there's some room for acceptance, right? Where you at, fortunately, and then kind of breaking it down into, am I doing too much? And I know nothing about you, Jane, so I want to be very careful. But this idea of sitting down, taking a step back, am I doing a lot? Because, and what are my priorities, right? There's working full time because it's financially supporting, because it's sexy and exciting. And then there's walking my dog and being out and with the nature. So putting that all together, I think can help see a bigger picture. And certainly it sounds like there's adjustments that are being made. So talking to your team about the frustration, we can't fix this. I truly wish I had a magic stick and I could be like, let's make wand, and I could be like, let's make this all go away. We cannot. So part of it is learning to accept some of the symptoms that we don't have control over, but then at the same time bringing it back to your incredible neuro team to kind of say, well, but what can be done? And then turning it back on yourself. What is it that you can do for yourself? So I also don't want to ramble. So I'll get to the apathy question. And then here he said, due to several years of Parkinson's disease, engaged with PT, speech therapy, OT, amazing, but all administered by Parkinson's therapists. Some only treat Parkinson's patients. Since my surgery, I'd like to continue with those resources, but I do not know if I'm a fit. Actually, I would love to answer that question. If you have a provider that you trust, they work well with you, don't run away from them. Have a clear discussion. Most of us are ethical. Most of us know our limitations. Talk to us. Tell us exactly like it is. You are complex. You have two very significant medical concerns. Is this the right person? So that'll be my brief answer to that. Incontinence. Here's what we know. 50 to 90% of patients have improvement post-surgery in incontinence. But again, we're getting older. Women who delivered many babies, for example, right? Like the bladder is just not the same, prostate issues. So there's often underlying medical issues that make that bladder still not cooperate. So we do know early treatments of hydrocephalus make it so that there's better chance of improving incontinence, particularly if it's directly related to hydrocephalus. I like bladder diary. I think it's a good way to help you train your bladder. But if just the idea of filling out forms kind of makes you vomit, then don't do it. Bladder exercises is another thing. I'm not a bladder specialist, but certainly meeting with a clinician who is and talking about what exercises you could be doing. And bladder schedules are a must. We typically say start getting used to those before and then stick to them after, and obviously need to adjust as you go. I hear you, Lori. Yes, not many people have opportunities to have a team. Yes, I totally agree with you. I want to talk about sleep. Sleep is your best friend. I see a lot of patients who tell me they have sleep anxiety. They're so worried about not being able to fall asleep. Anyone can relate to that? Nod if you can. Yeah, it stinks. But sleep is essential. So sleep is what gives us back that energy to be able to function the next day. We know based on research that post-surgery, many of our patients experience improved quality of sleep, which then further obviously enhances your recovery. Not shocking, right? If you're sleeping well, you're more likely to function better during the day. Little things, silly things, you're less likely to trip because you're more alert, you're paying attention. You're more likely to be cognitively engaged because you can keep up with the conversation, right? So not enough can be said about the fact that if we go through the surgery and then we also hyper focus on our sleep a little bit in terms of sleep hygiene, in terms of sleep diary, in terms of ensuring our bedroom is perfect for it, we are helping us and we're helping our brain recover post-surgery. Talked about cognitive functioning and surgery, and and sleep. Sleep hygiene. Raise your hand if you want to hear about sleep hygiene. Everybody knows about sleep hygiene. We can skip that part. I'm going to skip because you guys you know everything about sleep hygiene. Okay, cool. All right. Linda says, I do not have a shunt. My treatment of choice is therapeutic lumbar pressure with CSF extraction. I do procedure every 10 to 12 weeks. I also exercise as much as possible. Amazing. If this works for Linda, perfect. That's great.
So for 5 years so far.
Yeah, that's great. Ooh, sleep hygiene. Someone wants to hear about it. I'll be very quick. Sleep hygiene rocks. Few most important things to be thinking about when we're thinking about sleep hygiene. You ready? We go to bed at the same time. We wake up at the same time. Our bedroom should be dark. It should be cool. And the bedroom should be used for two things. Two things. Ready? Sleep and sex, nothing else. And the least favorite, this is why I get bad rep. No television. No television, no iPad. You're stealing the most natural melatonin. Go out to a different room or any other space if you only have one room. Watch that television. Talk to the grandkids, girlfriend, boyfriend, anyone you need to, your attorney. Talk to them on an iPad. Turn it off. Go to bed. Okay? You can't fall asleep. What do? You stay for hours and toss and turn? No, you get up. You get up, you walk around, you go back to bed. You're hearing me say this and you're like, Irene, I can't fall asleep without an iPad. I need my iPad. I need my phone. I need my television. Get a book. War and Peace is a great way to get yourself to sleep. Then start with the war part, right? So like, don't get to the love part, right? So stick with it. Stick with the most boring part and get yourself to fall asleep. You have racing thoughts, pen and paper next to your bed. Write it down. Okay, these are the best strategies. Cool. Sleep. What about use of drugs, Xanax, drugstore sleep aids? Talk to your doctor. You are complex enough. Some people say they can't fall asleep without Xanax. I'm not even a real doctor, right? I have a PhD. Talk to your doctor. Talk to your doctor, and most importantly, be informed. It's a decision you're making, what to put into your body. Be honest with your doctor. Tell him how many Xanax you're taking in, how often you do it, and be honest about your sleep hygiene. Do your own work. Be your own unbelievably strong advocate. Tell them like it is. Psychologically, I'm going to get Diane to that in just a little bit, I think. So I'm going to keep that question together with apathy. Okay. How are we doing on time? 6:46. Okay, we're good. So think about your action plan. Think about, what do you need to focus on? Do you need to focus on cognition? Do you need to focus on physical recovery? And then start little by little considering, what do we need to work on? This is where that baseline assessment comes in, which we kind of like, hopefully you hear what I'm saying in terms of like, it might not be always the best baseline. So we're thinking about you in your personalized recovery. You know yourself better than anyone. I'm here generalizing things quite a bit. But if you have always been the type of person who never paid attention, you've never read books, we won't expect you to start after the surgery or get really amazing at it unless you really want to. So we're trying to meet you where you're at. We're trying to keep things realistic. We're trying to do tailored approach. What are some of the activities that we think could be useful when it comes to keeping your cognitively intact? That's where the neuropsychologist comes in. I'm just going to go here for a second. When we think about cognitively engaging activities, I'm just going to put a plug here for a minute. We're thinking, as a neuropsychologist, I'm thinking about physical activity first. I don't think about puzzles. I don't think about games. I think about physical activity. The next thing I'm thinking about on my list is any novel activity that you have not done before. So you know how to the kids we say stick with the violin, or stick with chess. As we get older and we're utilizing these cognitive activities to keep us engaged, learn a new activity, and then once you're good at it, move on to something else. So the point I want to make here, it's as long as it's cognitively stimulating, that's what I care about. The moment it becomes something you're really good at, you can move on. You're not a kid. You don't need to stick with that. Okay. All right. So I just want to talk a little bit here about that. Okay. Cool. How are we doing? We're good? Not falling asleep yet? Yeah. Thumbs up, down. Okay. Okay, cool. Okay. Just gonna move. Few things that we're thinking about to avoid complications is following you closely over time. Adjustment your settings. It sounds like few of you have gone through this process. Figuring out optimal adjustments, knowing it might change. And then having discussions with you about what could go wrong. Giving you that information, which is why I do a lot of it's someone said about Parkinson's disease. I do a lot of these for Parkinson's support groups, and knowledge is power. The more you talk to others, the more community, the larger your community, the more you know. The problem is what you know could be scary, but you're getting exposed to this information. And as you become more exposed and more knowledgeable, you know how to filter the noise. Does it make sense? So you kind of like know what to pay attention to. Yeah. Okay. Cognitively stimulating activities. Just want to go back there for a second of this idea of learning a new task. We used to think we have one certain set of neurons, and then they leave us, Not the case anymore. We know that the neurons have chance to regenerate, but how do we regenerate them? We regenerate them by new knowledge, right? So if you don't have a tremor, but you're thinking of a new activity, start knitting. You always wanted to learn another language, go for it. Spanish, Yiddish, French, whatever you want, as long as you're learning something new. So find an activity and do more of that. It sharpens your memory. It improves your daily functioning. And here's something really cool. If it's an activity where you have to engage with others, it's so much better than one-on-one. Because what happens when you're with a community? You get to argue, you get to talk, you get to hear other people points of view. Do that as much as possible, and it's so much better than any other I don't know if I'm allowed to say names, but like any other activities that are computer games. Okay, I'm going to say it that way, like, so that it becomes a social interaction. I'd say this, my 2 cents, physical activity, new stimulating, cognitively engaging activities that are novel to you. And then if you like your Sudoku, if you like your activity that you've been doing for a long time, keep at it. So I'm not here to stop you from activities. I'm here to suggest that learning something new is the way to go. Okay. Cool. Harry says, for cognitive treatment, we'll see speech pathologists for cognitive therapy, but neuropsych has recently evaluated my post-surgery and will provide evaluation, hopefully go forward plan. Exactly. That's what we do. Yes. Cool. Okay. I'm going to address that apathy question. So the role of socializing, I'm here to promote your socialization, right? We're all kind of where you're listening to me. I get to talk, hopefully not at you, hopefully with you. But we are social creatures. We're meant to socialize. We're meant to be around other people. Do that. Do more of that. I have a whole talk on mood and kind of apathy that where I really like to emphasize. If you are not socially engaging, if you're forgetting your hearing aids, if you're starting to decline cognitively, you'll stay quieter. If you stay quieter, you'll say less, you'll be less engaged, people will be talking less to you. So when I'm thinking about apathy in my patients, I often ask myself, is it a learned behavior or is it part of the presentation of some other underlying disease? One of the things that we know is Parkinson's disease, hydrocephalus, comes with very specific cognitive changes. It does not come with a neurodegenerative disease on its own, at least initially. So when I hear that dad is more apathetic, grandma is more apathetic, mom is more disinhibited, when I'm hearing these neuropsychiatric changes, we're asking, is there another underlying process taking place? Or is that this really sucks? Hydrocephalus stinks. It's preventing us from being where we're at. That will make anyone apathetic. So we need to be digging a little bit to understand the baseline, to make sure there's nothing else going on. And if there's nothing else going on, guess what? Then we'll start talking about, this is where you're at. How do we help you, right? This is where a good therapist comes in, okay? Hopefully I've addressed that question. That was higher up. Being in a group of people improves your cognitive functioning. You have to be thinking on your feet, right? So here I am, like, I'm sweating a little. You guys are throwing at me questions. I'm anxious, but I'm still here. I'm still talking to you. I said to myself, you know what, Irene, if you don't know the answer, they'll forgive you. Hopefully, like, none of them just like walk out of the room, right? So this idea of, by socializing, you have to be thinking on your feet. That's what I want all of you to be doing. Because if you do the same thing, the same myelination path keeps going. But if all of a sudden you're having a discussion about an article you just read and someone gives you a completely different view on it, You're like, oh, that's interesting. Or you decided you will memorize your siblings' phone numbers, or you'll start memorizing poems and you're going to be reciting them. That's something new. And the neurons are like firing. Okay. Any questions there? Okay. So we have these rat models that we use once in a while. I don't. I'm done with rats, but they do show that social behavior and cognition is actually nicely linked. So the more socially engaged you are, the higher your cognitive capacity becomes. So this whole idea of like use it or lose it, right? Based on our testing, we see that positive association with verbal fluency and overall cognitive functioning. And we do know that socialization is actually a protective factor against decline and dementia. That's fascinating to me for the reason that the question is, are you super ager and you're experiencing underlying cognitive decline, but you're able to compensate? You came here, you've learned all this amazing knowledge. And although there might be underlying cognitive decline going on, you're using your cognitive attuneness to compensate. Okay, does that make sense? I just love that idea of this compensatory strategy and super agers and being able to compensate for cognitive decline through this cognitive engagement. Okay, all right, 6:57. I'm going to go for a few more minutes. I'm very passionate about subjective and objective measures because I spent so much time talking to you and to patients and to doctors about patients. And so we know that most positive overall experience is in gait, balance, cognition, contents. You're telling us you're feeling better. We're seeing improvements that you're telling us about, and we're also seeing objectively a much clearer direct connection between post-surgery and gait. We see improvement in balance and cognition, but you're telling us that you're improved more significantly than what we see on our data. Okay. The more optimistic, not delusional, optimistic you are about your progress, about your recovery, the more likely you will do better in post-recovery period. Does that make sense? Yeah. Okay. Hopefully, right? Okay, cool. So just wanted to throw that out there. How do I see this whole navigation of hydrocephalus recovery? Post-surgery rehab is a must, be it at home, be it hiring someone, be it going to PT, group therapy, swimming. We know that post-surgery rehabilitation leads to increased physical activity. And we absolutely want to do more research, but don't wait for us to prove to you that it's actually good for you. We know that cognitively you're improving. You're telling us you're improving. We see it on scores. We know our tests are not that great. So let us keep doing our assessments and tracking you, but do believe in the fact that you can improve cognitively or learn how to better compensate for the difficulties that you're having. Boosting your confidence, boosting your self-perception, boosting your ability to believe that you need to keep moving forward will improve your rate of recovery. This is a rare disorder, rare disease. Some of patients go misdiagnosed. So be your own advocate and reach out to doctors about symptoms. And if you're ever part of any other groups where you're like talking to people who are just starting this process, I think, I feel like it's my mission to kind of bring more attention to this. The longer we wait to diagnose, the more likely we are in this fuzzy zone of, well, where's my patient's baseline? Okay. Busy slide, but stay with me. Because that's how I want you to be kind of thinking of what needs to happen. We need to physically exercise. We need to stay physically active. We need to make sure we have an OT, occupational therapy, on our team, right? We don't have to call it OT, call it a cupcake. What I care about is someone is working with you on motor skills and coordination, right? Improving your functioning. Sleep hygiene. Thank you, whoever allowed me to cover that a little bit. That's awesome. I'm going to say something more about sleep because you guys are all still here. No naps, but if you absolutely have to nap, ready for this? First half of the day and time it. That's another unpopular thing to say, but here, I said it. Because then you're not really messing your cycle of going to bed at night. Medication management, don't doctor. Even if there are doctors in here, it's not a good idea to be your own doctor. You know a lot, but don't doctor. Go to your doctor, give them a list of medications. If you haven't been taking something consistently, if you haven't been managing your medications on your own well, talk to your doctors about it. Don't manage them on your own or decide when to take them or not to take them. Talk to a therapist. Talk to a therapist. No one should be going through this alone. I truly believe I've had a unbelievably strong mentor who once said to me that no one should be suffering alone. And I truly, absolutely believe that. We should not go through this alone. Thank goodness for this virtual space. I don't even know where Sierra, you guys are, and Trish. But thank goodness for this virtual space that allows us to all come together. I've done this internationally too, which I think is just fascinating. So you don't have to do this alone. Family, relatives, friends, have your support network, have your people around you to help you with this. And engage in community. Whatever your community is, do it. You're dancing, you're singing, you're playing chess, you're volunteering, you go to church, mosque, synagogue, whatever it is, find your community. Find your community and make sure that you stay actively engaged and it's not just a checkbox on your CV. I'm kind of done. So I'm all yours. Oh, there are questions. Harry says, exercise is very important to me. Exercise every day. Does NPH have guidance for exercise? With Parkinson's, rock steady, yeah, which doesn't include Parkinson, include NPH as a condition. So I'll say this about exercise. I'm not a physical therapist. The safer, the better. So I love when my older patients swim because I think it's one of the safest forms of exercise. You go into the water and there's, unless, what do they call it, corns, whatever you get on your feet if you walk in like dirty stuff, but that's probably the only side effect you're going to have. Swimming is the best. The other awesome thing about swimming is it gets your cardio up very quickly. So it had any exercise. Trish, go ahead, sorry.
One thing that we found, Irene, is that NPH robs some of us of our ability to swim.
Yeah, and actually the answer to that, I was going to say that when I say swimming, you don't actually have to swim. There's swimming, like water aerobics.
Yeah.
Just physically being able to move. My patients that move in water, it gets your heart rate up. So you're kind of fooling your system, your entire body as well, because you get your heart rate up, which is what we want, right? When the heart rate to go up, so there's more oxygenated blood going into your brain, right? So it doesn't have to be, I don't need you to be doing lapses. I just need you to be in the water, cute music going on, and you're moving your body. Anything that you do, I really want to emphasize this. Anything that you do, ask your doctor first. It takes a second to send that message through the portal or reach out to them. Just don't experiment. Your bodies are your temple. You've already been through a lot. Find out if it's safe. Chair exercises are great. I would love a cardio of some sort, but even chair exercises can get you into cardio mode. Yeah. as long as we don't fall. I think there's another, movement is a good thing. Totally agree, Lori. Yes, 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 particularly if it's safe. Yes. Anything else? Anything else? I think Sierra, can they unmute? Can folks unmute themselves?
Yes, you should.
Anything?
Everyone
Okay.
should.
So you can
be able
unmute.
to-
Ask if you have. Do you have any questions? Is there anything? I'm here to serve you. Anything else I can do for you? I was gonna tell my husband to take the chicken out of the oven. Take chicken out. Thank you. Sorry about that. Any questions? Anything you want to know? No?
We
Everyone
have
is
a
done.
couple people unmuting.
Just a second. I do have a real quick question about a neurologist versus the neurosurgeon. In my own case, I have regular visits with my neurologist, who was involved in my initial diagnosis. Then I went to a neurosurgeon and I had a shunt put in. I went post-operative recovery and everything. That was it. And I saw the surgeon. I no longer see him. I now only go to the neurologist. But the neurologist doesn't have the team that the neurosurgeon had. I mean, I think he had a neuropsychologist like yourself. He had a PT expert, etc., so forth and so on. And he is the one that got me into rehab after the operation. But after that, I've just gone back to my neurologist. Should I go back to my neurosurgeon?
The question I would ask is, what's your question? Not for me. Now, I hear your question, but what's the goal of going back? If you're doing fine, you're doing what you need to be doing, stay where you're at. You feel like something is not working, I do think something has to be said about going to the same team. I think as much as possible, unless you were dissatisfied with a neurologist, neurosurgeon, neuropsych, go to the same people. So I would say the question is, what's the point? If there is a point, if you need them, go back.
But what I was going to say is, when you're back to your discussion about a baseline, my baseline was really established by my neurosurgeon. Okay. So now 3 years after the surgery, the rehab procedure, and it was a thorough evaluation. And my neurologist, I'm very happy with him. He's a friend of mine. Okay. So, I have no problem with the physicians. The question is, the original baseline was with the neurosurgeon. The neurologist sort of looked at me, looked at my gait, checked it out, said, hey, we've got to explore a shunt. I know a neurosurgeon. Let's get you slotted there. So back to the baseline. The people that have the best baseline on me would be the neurosurgeon's team. I'm wondering if it's worthwhile, if I should go back to the neurosurgeon to get reevaluated against my original baseline. But I mean, I'll ask my neurologist about it. It's just
only if you need to. If you feel like there's been a change, you need more data points, you need more people to tell you where you're at. If not, stay where you're at. What's a baseline from a neurologist or neurosurgeon? It's data, it's numbers.
Yeah.
So they can either transfer that data, or if you don't need to, I want to be careful here, right? To me, curiosity is not always enough to go and get another assessment done. So if there's a good reason for it, of course, go back to your original team.
Okay, well, all right, that's good. I also participated in a study which put me through so many MRIs, I can't even count them anymore.
So again,
and
that's
that was
something
with
to
my
think
neurosurgeon.
about. Yeah,
so
that's
he
something
has
to think about.
Hundreds of slides,
right?
Of my brain and everything.
Yeah.
I just wondering if I mean, you're an academic, and and review data. I just wondered if there, about going back to the original provision of data and that original data.
Only when needed. You're not a number. You're a real human being, so only when needed. I think Janine had a question, if I know.
Well, thank you very much.
Of course.
I think Marion, did you have a question? You're unmuted.
Oh, no, I didn't have a specific question because I am one of those lucky ones that has no problems. Except for one thing. And you were talking about incontinence. I don't have incontinence and I can sleep, but I get up 10 times a night. And all the urologists, all the fancy urologists in this city have not been able to help me. I get up.
Went over there to see him. Was in there for about 15 minutes, and he wasn't.
Looks like we have some background noise from other people.
Okay, I get up about 5 to 10 times a night, and I go right back to sleep.
Her room, and I as I'm walking,
nobody has been. I don't want to have any kind of implants or Botox injections in my bladder or anything like that.
You don't know what you're going to say, like, why are you going back in this room? You're just being a creep.
So I'm going to get reevaluated by my urologist pretty soon. But I consider myself very lucky.
That's great. Janine, I think Janine had a question, no?
Yeah, or a couple statements. I think I'm the odd duck. I've never had a urine problem. Never. My mind is going goofy now. What was the other thing I've never had that you guys always are talking about? But I have, I think, the odd things that nobody else ever discusses. And I'm like, I feel like the odd duck. And so I've been seeing my neurosurgeon almost every 4 to 5 weeks. I had my 3rd surgery and when was it? September. I've had so many. June, September, maybe February. I've had so many of them. And I always, I feel really good in the beginning and then downhill right away. When I had my spinal taps, I had 3 of them. My goodness, after I had them, I could have jumped up and down, ran a marathon or anything. And within 2 days, it was gone. Maybe the first day after surgery, it was okay. And then, and so to me, it seems like it's not draining enough.
Yeah, Janine, that's a great question for a neurosurgeon. I want to be careful because it's clearly sounds like.
But yeah, if adjusting a number down on most shunts, is that increasing the flow and putting it up higher? Is that decreasing the flow? I'm getting kind of mixed messages on that because I'm kind of going up and down with that. And I'm going to one of the best neurosurgeons in the country. So I just do what he says. And I'm like, I feel like I don't always listen to you. Like the other day, I had an appointment scheduled for 11 o'clock or 1 o'clock. And then they sent me a note saying they had to change it to 8 a.m. And I got a hold of them again. I said, I can't do 8 a.m. I said, I'm 50 miles away. My daughter-in-law brings me and she has 7 kids to get ready to school. And one of them is a 3-year-old. So, it's almost impossible for her to get me there for an 8 a.m. appointment. Would, should have to get up at 3 o'clock in the morning, get the kids going, and all this. Yeah. And I called in and I keep saying, please. And they won't change it. I don't know how you can get them to recognize what's happening to you.
Yeah. Let me answer the part of the question. Let me answer the part of the question that I think I can answer. I apologize for to interrupting. Increasing the shunt setting decreases the amount of fluid drained. So I just want to answer that question, if that was a question.
Increasing the number.
Increasing the shunt setting decreases the amount of fluid drained. But again, this is all for neurosurgery.
Okay.
Okay. Anyone has any questions? Any other questions?
No, I just wanted to get the shunt thing done because I had a Medtronic and it came out in 4 weeks. They had to redo it. Put in another Medtronic.
Maybe you don't have the best neurosurgeon.
What?
You know, I mean, I've had one shunt for 8 years. I've never had a problem of any kind except peeing too much. In this, I have not seen my neurosurgeon in 8 years. I have no care team. I can't even find a neurologist here, but I don't need one.
Yeah. Well, I think
I've never had neuropsychological testing.
I mean, you all know Gary Shafee. Is that his last name?
Yes, yes.
And he's the one who recommended the guy at UT Southwestern.
Oh, yeah,
And
yeah.
the other people said, oh, he's great, he's great, he's great. That's who I'm working with. I started off with somebody else and then I went.
I'm sorry, I don't, yeah, I feel for you because, you know, I'm very lucky.
You guys, before we continue the discussion with Janine, I do want to make sure everybody who had a question for Dr. Irene got their question answered.
Oh, I'm sorry. Are there more questions? I apologize.
No, I
have
just
one
wanted to make
question about
sure.
driving.
About
driving.
About driving. Irene, are you able to answer questions regarding that?
Try me.
Okay.
Oh, I can see the chat.
Like I said, I live far enough away, and one day everybody was out of town. The few friends, because I haven't lived here that long, had Bible study, teaching or something on a day. So I drove myself down 50 miles. And I always have, someone else with me otherwise. And I said, well, I don't have my daughter-in-law today because she couldn't come. So I drove down. And Dr. White went, you drove down here? And I went, how else am I going to get there? Does anyone drive at all? I know Gary drives limited, very limited. And if you do drive, how much do you drive?
Yeah, I mean, just because I'm going to say this, right? Like, just because someone has an impairment doesn't mean they can't drive. The question is, are you a safe driver? So what we typically say, no neuropsychological assessment, no neuropsychologist will ever take your keys away from you. But what we do have is we have these tests that tell us if there's a correlation, if we're maybe concerned that your processing speed, right, the speed with which you're processing information, your ability to react may not be as good as it should be. And at that point, we could say, let's do a driving evaluation. And I have to say, in my experience, I've been doing this for quite some time, I rarely get a shocking response to this. Most of the patients who hear that I think they need a driving evaluation have thought about it. Others have told them that they need it. They just may not like it. They may want to, be mad at me and tell me where to go because I say that, but they're not totally shocked. So if you're concerned about your driving, get a driving evaluation.
Yeah.
You could always start by thinking, okay, if I have my grandkid with me, am I going to feel safe to drive? Right. If there is a kid running down the street with a ball, a truck driver who's driving and texting at the same time, do I have a reaction speed? Is my car full of scratches? Have I hit 3 to 5 poles yesterday? Have I gone into my car and forgot how to turn it on, right? So some questions are going to be like, you know what, I'm done. I don't even need to go through a driving evaluation because that thing is very stressful in itself. But if you're keen on driving and you're in situations where you have to, go for the driving test.
Some states have a mandatory driving assessment when you reach a certain age. Like in Texas, it's 80.
No, I'm
And
not there, not quite
I'm-
there yet.
Well, I am. And I'm very annoyed at this because I have not ever had an accident or a ticket or anything in my whole life, and I've been driving since 1962. But you know, I have to go through that because that's how I have to get my license renewed.
So they
Thank
tell
you
you,
for sharing.
What?
I've got, do they notify you or something? Like I'm
I don't know. They have.
75,
They
and so I
haven't.
don't know. Will they
but-
tell me?
No, they'll tell you. Yeah, they'll tell you.
Oh, okay.
They'll tell
Well,
you.
thank you guys for sharing, and thank you so much, Irene, for your wonderful wisdom and knowledge and sharing with us tonight. If nobody else has any questions, I am going to stop the recording.